much. I want to now turn it over to Caleb and his team for the next step. And we're going to continue to sort of move from 50,000 feet to 10,000, farther and farther down until we have all of these problems solved by the end of the day. Thank you.
All right. So when we heard in the beginning that one of the ideas we had when we designed this course was to try to port the value-based healthcare experience in Boston here to Southern California. And for those of you that have been out to the Boston course, one of the features of the educational model at Harvard Business School is the case study. The opportunity to put yourself in the shoes of someone who's facing a difficult management decision, work through the data, and advise how that decision should be made. We felt that it didn't make sense to have a 3-day case-based course here, but what we thought we could do is try to do something that was somewhere in between. So provide an opportunity to give you data, give you facts, and have you engage in that data to try to make a management decision based on the concepts you've already heard. So we're going to try it. It's kind of a new format. Hopefully you'll work with us. There are a couple of rules about case-based teaching that we will enforce here as well. The first is that the principle of the discussion is to debate the material of the case, right? So you can have opinions, you can share opinions about what should be done, but you can't say, well, in my experience, we did this at this hospital, okay? So it's not about sharing your anecdotal experience, it's about judging the information and saying what you think should be done. The second piece of case discussion, which is always fun, is that when you respond, you may get follow-up questions. Right? So if you respond, and I think we're going to have mics, but I think the room is small enough that we don't need it, there is an opportunity to kind of dialogue back and forth to further explore your thinking on a topic. So don't be scared of that. The other piece of the case method that Michael Porter would remind you is that there is certainly cold calling. We are not going to apply that here unless people don't raise their hand, and I don't think that'll be the case. All right, so I wanted to start out with kind of setting the context here. And this is a case that my colleague Jacob and I developed. We both actually worked with Michael Porter at Harvard Business School, so we're going to try to bring a little bit of that mojo here. Here's the setup. You are a regional cardio. I think we've got two. For the audience. For the audience. Good. Okay, so we will use this because I think we're recording, right? All right, so put yourself in the shoes of a regional cardiovascular service line director. You have responsibility for LA and Orange County. You've got a network of hospitals that you're over. And your job is the overall business strategy for that region and the operational care delivery. You have a partner, a physician partner, who you engage with in planning these things. You're really the operational leader. Okay? One day, you get an email from your regional CEO that reads like this. Joe, that's our character's name. We heard back from Optum today. They went with Kaiser in the Cabbage Center of Excellence RFP. They said we didn't have a clear center with enough volume and couldn't prove consistent quality. We've got to do something about this. We can't stand to lose any more commercial contracts. Joanne. This is a hypothetical example. This is not real. It is taken from pieces that have some semblance of reality, though. Right? So Optum is an arm of United Healthcare. They are going around negotiating bundled contracts. Their offer in doing so is we'll provide volume, but we want a good price. We want consistent quality. And in this hypothetical example, this hospital system that the service line director was a part of lost. They had participated in this process. They had submitted data on their volumes, but they didn't win. Okay? So this is the setup. One thing for our non-clinical colleagues, what is CABG? I know we have a few of those here. This is a heart. You probably got that part. The coronary artery bypass grafting. So there's arteries, these are the red ones here, that come out of the aorta, it's the red part, that feed the heart with blood and oxygen, right? If those blood vessels get blocked, we bypass them with either a vein graft, this is the blue one here, or an artery graft. So it used to be one of the most common procedures done, not as common anymore, but there's a couple of key facts about when and why the procedure is done that's helpful as we work through the case. The first is this is an intensive procedure. The risk of mortality is still 2 or 3%. Right, so it's not it's not as straightforward as a joint replacement. Although it's a bit intense procedure, most of these are still performed either electively, so before a patient goes to the facility, they can choose, or what's called urgently but non-emergently. So the patient would be admitted for ischemic heart disease, but they wouldn't immediately go to the operating room. There is a period of time to say, when is the patient ready for operation, and could potentially be transferred to another facility. And then the other piece that's important is usually patients who go to have cardiac surgery will have a relationship with a cardiologist first. Right? So the cardiologist is managing them medically. Many of those patients will have had a prior intervention, something called a percutaneous coronary intervention, which is where through a blood vessel, you're going through the patient's vessels to the heart, and you're sticking a stent to prop open the artery and keep blood flow to the heart. So it's kind of a less intensive procedure that for patients with less aggressive disease can be appropriate, right? So clarifying questions from the audience before we kind of move into the meat of the case? No, all right. All right, so you are Joe, you get this email, and luckily for Joe, you have a really good analytical team led by your colleague, who's represented here by my colleague, Jacob Lippa, and you basically just forward the email and you say, help me figure out what's going on here, why we lost to Kaiser, and what we might do about it. So I'm going to hand it over to our analytical colleague and tell us what he found.
All right, so as the hypothetical analyst in the case, my job is to present you the facts that you need to make a decision on how we're going to move forward with this. And it seems like at the heart of the issue, there seems to be both a question around volume and maybe a question around quality as well. So my first thought as someone in the clinical analytics department, because I eat and breathe and sleep data, is where do I get some data to inform this decision? And thankfully, there are some mandatory reporting requirements here in California, and the statewide Office of Health Planning and Development keeps statistics on volume for all PCI and CABG procedures around the state. So thankfully, I can call them up and I can ask them for a data set. And because, of course, we know our own volumes, but we don't necessarily know everyone else's volumes. So I can say, hey, can I have a data file that includes total discharges by year, by DRG, by facility for the following DRG codes? And then not only that, but can you also give me the geo coordinates of all of those facilities so I can narrow down my analysis to a specific hospital service area? And they say, sure, and actually send that data file to me the next day, which is fairly remarkable, but actually true. And so I think most people in the room are familiar with the Los Angeles area, but wanted to give you a sense for the region that we're talking about and the size of the region specifically. So this is our LA area, this is downtown, we have San Fernando Valley over here, San Bernardino, and Orange County. And if we just overlay, just to give you a sense for how large of a region this is, we're talking about essentially 50 miles in radius from downtown LA. And then what we do is we plot all the hospitals who have performed either a CABG or a PCI in the last 3 years onto that map. And what we find is 59 different hospitals did at least one procedure. The next step in terms of just getting a sense for what the overall market looks like before kind of drilling down into our system or anyone else's, is to resize these bubbles based on their total volume of cabbage and PCI. And when we do that, we see this picture. Fairly fragmented market, a lot of procedures distributed across the region. And it's not surprising that when we drill down further into only PCI, because it's a much more common procedure, the image doesn't change much. And then finally, we can do it one more time, and we can see the 11,000 cabbage procedures over the 3-year period, 2015 to 2017, by volume. And here you do begin to see a little bit more differentiation. And just one other note on these maps, the sizing of the bubbles is relative to the other facilities. So it's not always equal size for equal number of procedures from map to map. So okay, we have a pretty good sense for what the overall market looks like in terms of the distribution of volume of these procedures. The next step then is to say, okay, where does our system fall? How does our system look? So if we just look at the 9 hospitals in our hypothetical system, we see some groupings. First of all, we have a few hospitals up here near San Fernando Valley, a couple down here, Orange County, and then a few here in between. So I think that's one important piece or fact to keep in mind is kind of the geographic spread or layout of our hospitals. And then we can do the same kind of drill here where we look at total discharges, and we see very even distribution. I think around 3 to 6% of the total system's volume across these centers. So no one really has what we would say is a dominant share of these procedures. And then again, looking PCI only, it looks very similar, of course. And then when we look at cabbage, we see these guys up here in San Fernando Valley seem to be slightly smaller compared to that last image of PCI. So I'll just flip back for you. So this is our system. So that was one piece of the question or the answer that I was trying to provide, is what does our system look like relative to the overall market? And when you overlay the two with our hospitals now in green, you get a sense for the overall market share and where we land. And then again, for cabbage only. And what we notice here, and I'm not sure if you caught this the first time around, is that we do seem to have a pretty large center right in downtown LA that seems to be capturing quite a bit of the cabbage volume. And what's really interesting is that it's the same hospital that's the market leader in the total procedures, but here they only have 7.5% of total volume of PCI and cabbage. When we look at cabbage only, that number jumps to 16% of total market share. And it turns out that this is the center that Joe's boss was writing him about that won the contract, the Kaiser Foundation Hospital in LA. So if we just isolate those guys real quick, what I find really interesting when I looked at the data was that despite the fact that so much of that volume is in one Kaiser center, Kaiser actually has 8 hospitals in just the LA region. So this kind of got me wondering, why is so much of their cabbage PCI volume going to one center? And it turns out that if we look at their total discharges, that is in fact the case. About 75% of their volume is going to downtown LA. If we look at PCI, slightly different, but still dominating. And then this is the kicker. Their entire cabbage volume in one center in downtown LA. So I just wanted to leave you with this. This is looking at cabbage from our system just compared to Kaiser now. And what's really fascinating about this, and I didn't have the numbers on the slide, is this is an almost exactly equal total number of cabbage procedures. Except in our system, it's spread out across 9 hospitals. In Kaiser, it's concentrated in 1. And we think that there might be something to this, and this might be also have a connection to the outcome piece that led to the exclusive contracting arrangement as well. So we wanted to dig into that a little bit further. But first, we wanted to look at what the association was, if any, between volume and reputation, and how volume might actually factor into some of the common ranking methodologies that we see publicly. And when we rank all the hospitals in the LA region by their volume, for this is PCI and cabbage combined, and then we highlight the ones in blue that are ranked in the top 10 for LA area for cardiology and cardiac surgery specifically, we see that 8 out of the 10 highest volume centers in LA were also ranked in the top 10 by US News and World Report. And the other interesting thing is that only two that weren't are academic medical centers who are publishing prolifically and probably extremely high quality despite low volumes. So the final piece of this is to look now, turn our attention to the outcome piece and look at whether there's an association between volume and quality as we do see in a lot of other condition areas. So this is taken from an article published in the Journal of the STS that looks at both mortality risk by volume as well as overall quality composite, which adds in additional measures of morbidity and process of care measures. And what you see here is that the risk does, even after adjusting for patient risk factors, that there does seem to be lower risk of mortality as your total CABG volume increases, as well as you can see here, this lowest group tends to have a lower, statistically significant, lower overall composite score than the two highest hospitals in terms of their volume categories. So there does seem to be something to this. But of course, we're always skeptical of peer-reviewed publications, and we want to know, does this actually hold true for our hospitals? So we again dig into our data, and we find, a similar trend. So we see in our own data that yes, we see that that quality is still good in our lower quality hospitals, or lower volume hospitals, excuse me, but it's a little bit more variable. So there does seem to be something to this quality piece as well.
So he's a pretty fantastic analyst, right? We have on the team. So reorienting ourselves back to this cardiovascular service line director, he received this email, he forwarded it to his analytical team, and this is the kind of the packet that the analytical team places on his desk the next day. So he's kind of digesting this and thinking through it. And so the question back to you is, what's your reaction? You see this data, you're considering the email from your boss. What's going through your mind?
I think it comes out to be a
Okay, so maybe we need to do something about this. We need to create a center. And why? Why would we create a center?
You have a center so you have more volume localized in one place, not so spread out, and then you can get a graph that's more similar to this.
Yeah. So, and what do you think the advantage are from aggregating that volume?
That you're going to get better outcomes for lower cost, which will appeal to your optimum people.
Okay. So maybe this theory might be able to play out in reality. Others? What else is going through your mind? Yeah? Okay, so you're saying maybe it doesn't all need to be in one place.
Yeah.
Why would you do two instead of one?
Because that's easier for patients in different places. Maybe that will be a competitive advantage rather than one place. I mean, compared to other company, you will have two big ones.
So you're reflecting on how nasty the traffic is here,
Yeah.
and you're wondering maybe we have to be realistic about how much we can aggregate. You know, I think it still blows my mind how Kaiser is able to manage that. They have a
I don't think they
helicopters.
start from that point. Maybe it's gradually, after 20 years, maybe 30 years, they have that center.
Yeah.
I don't think they build it in 1 month, or maybe that's not a plan. Gradually, they gather that number of patients in that one place.
So you're thinking through the practical ramifications of how do we do this consolidation. What else is going through your mind?
I was thinking it from a lens of consumerism,
Yeah.
and to be able to get people to travel all the way from Orange County or down from San Diego to LA doesn't seem fair. So having multiple points of access would be appreciated from the consumer lens.
So you're again raising the kind of the practical challenges from the patients given the travel in this area that might need to be considered. Others? Gail? Yeah.
right? So there's data we don't know, and we don't know that Kaiser did actually contract with St. Bernardine's to address that. So my question would be, what don't we know?
Yeah.
And how do we learn that?
So maybe some healthy skepticism. I think that's a really good point. Are you convinced yet? Certainly we've presented one piece of the story, but if you wear your skeptic hat, what else might you want to know before you feel comfortable moving forward?
The more that you focus volume in one place, it allows for greater standardization and reducing variation, like Amy Compton Phillips mentioned, and it just allows you to focus more on that specialty, so your outcomes improve.
Yeah. So you're saying one thing you're thinking about is what are the relative advantages that we could kind of sell to the important decision makers that this is going to be better for at least some portion of our stakeholders.
Yes.
Next to you.
You also condense resources for that specialty as well. Instead of having 9 hospitals with cardiovascular operating rooms, you could have 1 or 2, and that helps reduce costs for all those resources as well.
So we address the quality piece, but cost component, particularly the fixed cost of care, also might be a key component. Yes?
I think you're balancing at least 2 variables here. One of them is patient access on the one side, and the other side is efficiency and quality. So one of the things that would be interesting to know is, are there diminishing returns on volume? We've already seen higher volume gives you lower cost, better quality.
Yeah.
But are there diminishing returns? And if there are, then might 2 centers where patient access comes into play would be beneficial to you.
Yeah, I think it's a really important point that we're hearing throughout the audience. Yes?
There may be less comorbidities in patients that are at Kaiser versus some of these other hospitals that take in patients that aren't getting, multiple levels of access to get care, to take care of diabetes, all the things that affect outcomes and duration of hospital stay after the surgery.
Yeah, so if we're putting our hat on of a physician who might be practicing in the hospital who we're saying we need to take your volume because we don't think it's high enough quality, we're saying maybe we're not telling the full story here. Maybe the patients are different. Yeah.
I think one of the things that we might want to also look at is, I think there was multiple sites that we have, right? 8 or 9.
Yeah.
So maybe looking at best practices, and maybe one of those sites that may be doing really good in quality, and that's why we failed to get the contract.
Mm-hmm.
So maybe that's sharing, and then also maybe possibly looking at some of the services that we are good at, we can keep those, and then maybe also asking about a possible affiliation in the area.
Okay. All right. So we're going to pause this conversation. I want to kind of poll the audience based on what you know now. Do you feel confident that you can see an uphill battle here? Do you feel that the battle is going to be worth it? Do you feel like, this is a challenge I'm ready to take on to try to consolidate these services across my region? Who feels they're kind of ready to make that bold decision? Okay, all right. Well, there are a few. The path is for the bold. What we wanted to do in the second half of the conversation, which probably will help the other part of the audience, is think through how that would actually happen. Okay, so back to our protagonist. He organizes a meeting the next day, and he happened actually to study political science in undergrad. And he says, I think this is fundamentally a political strategy problem. Like, we've got all of these decision makers. We got to figure out who has the decision power and how we influence them, right? So he brainstorms a list of potential decision makers, people who are going to be either for or against this idea, right? So what we're going to ask you to do is take a couple minutes, 2 or 3 minutes, take a look at this list, and maybe I think it's probably pretty straightforward who these people are. When we say hospital operators, we mean the executives of the hospital, so that the CEO. The community boards are they are responsible for who the hospital reports to. They're responsible for bringing the perspective of the local community. Obviously, the cardiac surgeons are doing the cases. The cardiologists are often referring the cases. Primary care physicians may also be referring, et cetera, et cetera. Okay, so what I want you to do is take a couple minutes, take out a piece of paper, and I want you to rank, pick your top 3 people who you think are going to influence this decision for or against. Okay, like your stakeholder map, top 3, and then write down next to your top 3 what their primary motivation is. Okay, so what's going through their mind. So if you write down a cardiac surgeon's, what's their reaction going to be to this proposal? Okay, so take a couple minutes, write down your top 3 and what you think their reaction is going to be. All right, let's just take one more minute. All right, I'm sure most of you are still thinking, but I'm just going to move us along here for time. What I want to do is do just a quick voting round, and then we're going to focus the discussion in on the top 3 vote getters. All right, so who listed hospital operators in their top 3? Okay. Hospital community boards. Cardiac surgeons. Referring cardiologists. Primary care physicians. Other specialists, nursing staff, EMS operators, patients, and health plans. All right, that was pretty close between patients and health plans. I think it was very clearly the hospital operators, the cardiac surgeons, the referring cardiologists, patients, and health plans were all kind of in the mix. I think all relevant. Let's start with the hospital operators then. For someone who listed the hospital operators in their top, what did you think the reaction might be? Jens?
We are going to lose a very, very important revenue stream and potentially also profits.
Okay. Fear. All right. Anyone else? Hospital operators?
I think definitely doing cabbages is a very prestigious procedure, and you want to be able to say that. But in terms of the revenue, actually, one of the questions I had is for the hospitals, whether or not it really is a profitable procedure, and if they are or not making profit, would also be a balancing factor as to whether or not they really do or don't want to keep that there.
Right. So there's the revenue we know is there.
The prestige.
So the profitability is a different thing.
Yes.
And the prestige, an open question. Other thoughts on the hospital operators, how they might respond to this? Now, remember, we have 8 hospitals, so 8 hospital operators. Do they all stand to lose? What are? All right. So maybe that should influence. If they stand to gain and stand to lose, does that tell us something about how we might organize our decision power within a region and how that might influence the ability to do something like this? If you're a local CEO and your responsibility is only your facility, then you might have a different incentive than if your decision is how do we optimize the regional performance, correct? Right. All right, so hospital operators concerned about revenue loss, got to think through how to mitigate that, maybe replacing the volume, maybe changing the performance model in which they operate in. Okay, let's go to cardiac surgeons. Someone who listed cardiac surgeons, what did you think their reaction was going to be? Yes?
The cardiac surgeons, if their contracts are based on volumes and quality metrics, if they have performance-based contracts, they may be concerned about what the expectations would be in terms of volumes under new contracts.
Do you think they may be skeptical that they'll get their volume to follow them in a new facility?
Right, or they may, what would be the expectation around quality performance?
Might be some fear that the expectations are higher than they currently have. Okay. Other thoughts? What might be going through the cardiac surgeon's mind?
Kind of forcing me to drive from Orange County to LA to do all my surgeries every day. Why would you? I feel like it'd be a negative deterrent. Maybe look for an alternative job and not want to consolidate.
Yeah.
In that nature.
If you've got a lovely house in Laguna Beach, you're forcing them to move up to San Fernando Valley. You're like, sorry, that's not for me, right? Okay. Other thoughts? What's going through the cardiac surgeon's minds? Yeah. Why do you say that? Yeah. So we're moving from a pond to a lake, and their relative fish size might be different than what they're used to. Okay. So I was almost at risk there of sharing a personal anecdote, which would have, I'll have to save that for the end. I have to follow my own rules. Okay. So the next piece we talked about was the referring cardiologist. What did you think the referring cardiologist reaction might be? David?
Please do not give me cardiac privileges. But if you move the higher risk cases away, there may be PCIs and other procedures they don't either get to do because you can't do them without immediate cardiac backup, and or they'll lose the prestige at their local environment. So I think that's an issue.
Okay.
And then let me tag on one thing for both the physician groups is you're going to get feedback that you're telling me a quality score of 94.8 versus 95.2 really means something, right? Go back to the data fields. That's, it's kind of like the patient satisfaction data that it doesn't make as big a difference. See, look at the scale. If you blew that up from 0 to 100, you wouldn't notice the difference, I guess. And in my experience, physicians really hone in on that type of thing.
So there might be some skepticism that these trends that we see nationally, the relationship between outcomes, cost, and volume, may not play out locally because everyone's an exception to the rule. Their quality is always going to be better. All right, so you're concerned that the referring cardiologist are fearful that the scope of their practice might be reduced without cardiac surgery nearby. Any other thoughts how the referring cardiologist might react? Jamie?
I think there's a common theme between all of the people, which is fear of loss.
Yeah.
Which, whether it's the hospital, operators, cardiac surgeons, the cardiologists, everybody's going to fear that they're going to lose.
I think you pointed out very correctly in your previous work that fear is much more powerful than the potential gain that may come. Okay, let's move then to the patients. We'll pick up a fourth one. What's going through now? Obviously, the patients aren't making this decision, but thinking on behalf of the patients, what reaction would they have when they hear about this, David?
Yeah, that was, I put patients down as one of mine. What strikes me about the anticipated responses is how no one is focused on the patient's perspective, the customer's perspective. And I'm going in for heart surgery. I want to know I'm going to have a good outcome, and I'd probably like to know what my costs are associated with this. And, based on what I'm seeing, it's more of the opaque, trust us kind of a way of doing things. So ultimately, the companies that can connect with customers and patients and earn their trust, I think, win. And that isn't a part of the reactions at all. It's the fear Jamie's talking about, not the hope.
Yeah, stay with your mic because I got a follow-up question for you. So you're speaking to your past points because of the messed up incentives and the structures. Our alignment towards the consumer to the ultimate receiver of these services is not great. People mention the practical challenge of travel here. You're mentioning the potential benefit. How might you think a patient would balance those two? And if we were to do this, how might we help them be an advocate rather than a detractor?
Well, honestly, if I'm having cabbage surgery and I need to travel an hour further to get the best outcome and the best experience, that doesn't bother me at all.
So maybe we have to be
you got to sell quality and experience.
Yeah. So the purpose of this case study was to articulate the change management, the kind of political challenges of the organizational strategy of value-based healthcare. It is a, yeah, sure.
And I'm not sure, maybe this wasn't your question, anticipated response. I think everything that we said here, to your point about the patients, what we said about the operators and the surgeons and the referring is that, yeah, maybe that's their first gut quick reaction, but I honestly think that if you do sit down and talk and show the data, you'll be able to show that value and value to the patient is value to them too, and that it is actually a positive win for all of them. I don't know if you meant that in anticipated response, yeah. But I think all of those players would be able to see the advantage as well. I mean, they would have fear, but I think there's certainly some advantage to them too.
Yeah, absolutely. Very well stated. A very nice closing to what is a challenging change management exercise, but is in the service of good, right? And that the purpose of our case was to kind of help us plant these questions of how do we navigate the change, because in our own system we have an experience of doing this in Portland that our colleague Dan Osseran will speak to. But I think it gets to your point is it's not easy, but if we have the leadership to sell the ultimate value, perhaps we can accomplish it. So thank you for your participation. Hopefully we've planted good questions and teed up Dan's talk.